My name's Darryl Beresford. I'm a specialist prosthodontist on the Gold Coast. I've been practicing dental implants for 20 years. We've placed in excess of 5,000 implants. Now today I want to talk about particularly the all-on-4 technique and some other options to help solve problems with dentures. These are heavily marketed and poorly explained. Just going to have a little chat about what the all-on-4 is. It's a technique that's been heavily promoted around the world, and a lot of the general public have become aware of it through radio and television advertising. And it has some advantages and some disadvantages. It can be a good technique, but it's not the only technique. There are other ways to help people. So we're just going to go through and just explain a few different options and the history of dental implants to somewhat. So this is some all-on-4 work on the top left-hand screen here. This is, again, what most all-on-4s are. They're high-quality denture teeth on a resin framework with metal substructure, when the metal holds it all together. And so that really is just a bolted-down denture. Here on the lower right-hand screen is just the same thing as the complete removable denture. Just high-quality denture teeth, high-quality resin, well-made, conventional denture. Now this particular denture is what we call a suction denture. It's invented by a Japanese chap, Hiro Abe, and it's just a modified impression technique which sometimes gets you very good suction. But again, the teeth are the same, the resin's the same. With the all-on-4 it's bolted down. Now what's been marketed heavily is this all-on-4 and Marlowe technique, where the distal implants are tilted and there's 4 implants and 4 screws. And again, what it really is just a bolted down denture. So it's very stable and people can chew. They're very satisfied with the chewing ability. It has certain disadvantages in terms that there has to be some reduction with the removal of the teeth, reduction of the tissue, and this just sits just above the tissue, and sometimes it's a little bit hard to clean. People sometimes find it a little bit annoying, but generally they're very satisfied with the treatment. But there are other options. And there are other options that we've tried over the years are a 2-implant overdenture with 2 press studs, or a 3-implant overdenture. Now, they've got a high satisfaction rate on the fixed bridge, but there's also a fairly high satisfaction just on a complete denture with 2 or 3 implants. So if you were to look at the scores of people's satisfaction and you measured them after their treatment and you got them to rate from 1 to 10, quite often the fixed bridge would come up about a 9 or a 9.5, and the overdenture would be about a 7 or 8. 2 implants would give you about a 7, 8, a little bit higher generally with 3 implants or more because it's more stable. Now the problem with the maxillary case is that when Marlowe did his early studies, he had on these machine surface implants quite a reasonable success rate. But when he went into the maxilla, because of the maxilla the bone level is much softer, it's less dense, as he described it in an interview once, that it was disastrous. It fell to about a 70% success rate. So he then went back to the drawing board and reinvented the implants and made the implants more tapered, under-drilled the preparation, angled the implants, and he was able to get his success rate up to quite a respectable level. Now the problem in the maxilla is that his technique, the Marlowe bridge, requires significant reduction. And in some cases where this bone is very damaged, that can be a good technique and it'd be the best thing for the patient. And in other cases it's not. You can cause aesthetic complications. And if you reduce all this tissue back, sometimes there's no bone left for the implants. So although the Marlowe technique, or the all-on-4 technique and the Marlowe bridge has many advantages, there are also some disadvantages. And unfortunately, a lot of practitioners who are general dentists are going to these courses and getting out and doing these procedures without being aware of all the other potential treatments that are available and the advantages and disadvantages and the risk and the cost benefit. Now again, most of these Marlowe style bridges, they're one piece. The definition of the Marlowe bridge, it's one piece and there's no gum. You reduce the gum in the bone back, you make this flat so it's easy to clean. So the concept is it's flat, easy to clean, No gum to worry about resorbing. You've chopped it all back. It's all in the vacuum cleaner or the rubbish bin. And then it's really just a bolted down denture. And the other very popular thing at the moment is the same day teeth, or teeth the next day. And so what they're doing is they're getting some laser welding of some metal framework and then bonding basically what's denture teeth on. If you look very closely, this is one that was done in another practice, and after a couple of years we already have a crack in the framework. Now another disadvantage is they're difficult to clean underneath. As a practitioner, I can't inspect these implants. I can't check if the implants are healthy because we have a big piece of plastic that's overlaying the implants. I can't probe the implants, I can't look at the implants, I can't look at the colour of the implants, and I really don't know what's going on with the implants. Now, there are a few claims that are made about these techniques. Now, one thing they'll say that it's revolutionary, it's a revolutionary technique. Well, the revolution in the mandible is simply to tilt the implant, and that hasn't shown to be any advantage. There's probably no disadvantage, but there's no real advantage in most cases. Slight biomechanical advantage to the framework, but there's no clinical advantage to the implants. When we got into the maxilla, that was a little bit more revolutionary when he redesigned the implant and came up with his own implant design and walked away from the standard parallel-walled old machine style of implant. So yeah, there was some clever design work, but it's not revolutionary. It's just a bolted down implant bridge. Some implants and some denture teeth bolted down. There is a newer version out which has got ceramic, zirconia, and they're a prettier looking alternative and they're a better finish, but it's still the same thing. It's just a bolted down bridge. So this is one that was done in another practice some distance away. This is one that we did. Now, we did this case, we did an all-on-4, and we did this in 2 hours. The surgery literally took 2 hours. The provisional was pre-made, we adapted this back, and that's designed to last 6 months. It wasn't presented to the patient as a permanent solution, but as a provisional solution. And the way I tend to operate is to make a provisional within a couple of hours, and then go back and adapt and fine-tune the tooth position.